Um, I have been lucky enough to present on this topic a couple of times now, and each time I tend to add a few extra things in based on the feedback that I receive or questions that are answered. So I have been quite ambitious with what I'm planning to talk about today. If any of you have seen me present on this topic before, then you'll probably notice that I am using a lot of the same slides, but hopefully I've got enough new content in there for you to still get lots out of today's presentation. So kicking things off, I always like to begin by providing an outline of what I'm going to cover, just so you can track where we are at the presentation as we go along. So I'm first going to talk around what we know about what causes pancreatic cancer, who has an inherited risk of pancreas cancer, and what that risk is, if there is a faulty gene or a family history. I want to talk a little bit more around the process of a genetics assessment, what it involves, and potentially who should consider genetic testing. And if a genetics assessment indicates that you have an increased risk, what you can do about it. I then want to explain in a bit of detail exactly why we're running our screening trial, who we recruit and what's involved, as well as a general discussion around some of the potential benefits and the potential limitations or risks of screening. I'll then summarise everything into my main take-home messages and hopefully leave plenty of time for questions as well. So, what causes pancreatic cancer? The very first thing that I want to make clear is, like all types of cancers, there are actually many different types of pancreas cancer. When I refer to pancreas cancer, I'm actually talking about pancreatic ductal adenocarcinoma, or you might hear about this being referred to as PDAC. And PDAC accounts for the majority of pancreas cancers. There are some rarer neuroendocrine tumours or other rare subtypes. Now, some of these do also have an inherited risk, but they're not really the types of pancreas cancer that I'm referring to today. We know that majority of pancreas cancers are caused by environmental or lifestyle factors. Some of these factors we can't do anything about. Simply getting older is a risk factor for pancreas cancer. We know that when it is diagnosed, it is most commonly diagnosed in individuals who are over the age of 70. We also know that males have a slightly higher risk than females for reasons we don't yet fully understand. But there are a number of lifestyle factors that are associated with a very high risk of getting pancreas cancer. And you can see these here in bold. They include smoking, being overweight or obese, or having type 2 diabetes. Other exposures to chemicals such as industrial or agricultural chemicals, excessive alcohol consumption, and things that cause chronic inflammation of the pancreas are also known risk factors. I guess what we're here to talk about today, though, is a smaller proportion of families or individuals where their pancreas cancer is linked to an inherited factor. And our current evidence suggests that this is around 10% of pancreatic cancer diagnoses. This could be because a person has a known cancer predisposition syndrome where a specific faulty gene has been found, or it could be that that individual has a family history of multiple relatives with pancreas cancer. And even if we can't yet identify what that specific gene fault is or the specific inherited factor is, we can still refer to these families as having familial pancreatic cancer. So who exactly are these individuals with an increased risk, and what is that risk? This table lists the cancer predisposition syndromes linked to the highest lifetime risk of developing pancreas cancer. As you can see in the top two rows, there are two syndromes linked to a very high risk of pancreas cancer: hereditary pancreatitis and Peutz-Jeghers syndrome. And you can see that that risk is up to about 36 to 40%. Thankfully, these syndromes are very rare, But it is incredibly important that we identify individuals who have this syndrome so that we can certainly put in place the right health checks for them. As we move down the table, we see a number of other syndromes with an increased risk, albeit a lower increased risk of pancreas cancer. And some of you may have heard of hereditary breast and ovarian cancer. This is a syndrome caused by gene faults in the BRCA1 and BRCA2 gene. And we know that particularly for BRCA2 gene fault carriers, there is an increased risk of pancreas cancer of about 5% across their lifetime. More recently, some other genes have been identified, including PALB2 and ATM. And whilst we don't yet have sufficient evidence to put a number as to how high that risk is, we do know that it is increased above that of the general population. Taken together though, all of these syndromes still only account for around 20% of high-risk families. The remaining families fall into the classification of having familial pancreatic cancer. By definition, familial pancreatic cancer is the presence of 2 or more first-degree relatives in a family with pancreas cancer. And when I say first-degree relative, I mean a parent, a sibling, or a child. And as you can see in this table, a person's risk of developing pancreas cancer themselves is known to increase in proportion to the number of affected first-degree relatives that they have. So if we compare a risk in the general population of developing pancreas cancer of about 1.3% across a person's lifetime, an individual who has one first-degree relative with pancreas cancer, say a parent, their risk increases to about 4% across their lifetime. A person with 2 first-degree relatives, say a parent and a sibling, their risk increases to 8 to 12%. And you can see that it's higher again if there are 3 or more people in the family with pancreas cancer. It's not just the overall number of relatives. The risk is also higher if there are young ages of diagnosis of pancreas cancer in the family, and anyone with this inherited risk who is also a smoker, that increases their risks further and also lowers the age at which their cancer is likely to be diagnosed, which is why it is very important that individuals with a family history of pancreas cancer abstain from smoking. So as a genetic counsellor, one of the things that I talk around all the time is the process of a genetics assessment. And I wanted to talk to you a little bit about what this involves and when it might be helpful. The first thing that I always like to stress is there is a difference between having a genetics assessment and having a genetic test. A genetics assessment can be helpful for everyone, but not everyone will benefit from having genetic testing. Anyone, as I said, can have a genetics assessment. It can be a person who has been affected by cancer, or it can be a member of the family who has not personally been affected by cancer. But when we do genetic testing, it is always most helpful if it is a member of the family who has been diagnosed with cancer that is tested first. There is a process for how we assess if genetic testing is likely to be helpful, and that's based on how likely it is that we would find a particular genetic fault or a mistake in a gene that is that explanation for the family history. And at the moment, our criteria for publicly funded genetic testing is when an individual is assessed to have a greater than 10% chance of finding a gene fault. There are some scenarios when a genetics assessment is recommended for a person with pancreas cancer, and I've listed some of the potential criteria here. Anyone diagnosed with pancreas cancer at a young age. Now, I've listed here under 50, but also noted that some services are now suggesting a genetics assessment for anyone diagnosed with pancreas cancer under the age of 70, though I do note this does still differ state to state and even genetic service to genetic service. If there are 2 or more relatives in the family with pancreas cancer, particularly if they are first-degree relatives of each other, then that family will meet familial pancreatic cancer criteria and should certainly have a genetics assessment. If a person with pancreas cancer has a family history of other cancers like breast, ovarian or gastrointestinal cancers, particularly if they are diagnosed at a young age, or if a person knows that one of their blood relatives has been found to have a faulty cancer predisposition gene, then it's important that they determine if they are also at risk of having that particular gene fault. And even if you don't fall into these criteria, some people are now becoming more and more interested in self-funding genetic testing, and this could be something that could be a viable option for certain families. So when you have a genetics assessment, it first requires a referral from your GP or a specialist to a genetics service. You'll usually be linked in with a genetic counsellor, and that genetic counsellor will begin a process of this assessment. This will mean that person will take a full family history. They will try to verify information about the specific cancer diagnoses in the family, and that could include trying to locate pathology reports or death certificates for this information. In some scenarios, there are risk assessment models where this information can be inputted into a computer, and that can calculate the chance of there being a genetic fault in the family. Some of these syndromes have physical features that a doctor can detect by doing a clinical examination. And based on that risk assessment or that clinical examination, the genetics team will then determine if they recommend genetic testing. And incorporating any of those genetic test results, you will then be provided with cancer screening recommendations, and usually they'll also provide some recommendations for your close relatives, such as your children or your siblings. If we look into a little bit more around what exactly genetic testing involves, again, the first thing for me to make clear is that there are actually two broad forms of genetic testing. All genetic testing is looking for a spelling mistake in a gene or a change that means that that gene is not working properly. But that testing can look at two different parameters. The first type of testing is what we call somatic testing. This is looking for a change that has occurred during your lifetime, something that you have acquired as you've gotten older, often within the cancer tissue itself. And this can help to determine what's driving that tumour to grow and to develop, and what treatments might be most effective on that specific tumour. The other form of testing is what we call germline genetic testing. And this is looking for an inherited change, something that is present in all of the cells of your body, something that you have been born with. And we do this particular test on a blood sample, and this can help us to understand if you have an increased risk of developing cancers. So if a germline gene fault is identified, it tells us that you have a gene that is not working properly. And because that gene would normally be protecting you against developing certain types of cancers, the fact that it's not working properly means that you have a higher risk of developing cancers compared to the general population, but it does not guarantee that you're definitely going to develop a cancer, and it can't predict exactly what type or when you might develop a cancer. The way we do this particular genetic testing these days is typically by doing a test called a gene panel. And what this is doing is looking at multiple genes linked to pancreas cancer at the same time. That gene panel could be a small number of genes. So for example, we might be testing BRCA1, BRCA2 and PALB2. Or we could be testing a larger number of genes. And this is usually something that is individualised for a particular person based on their personal health history and their specific family history. Unlike any other blood test that a person would have, genetic testing can also have very important implications for your blood relatives. And this is because, by definition, genetic information is shared information between your blood relatives. If we go back to the very basics of cancer or of genetics, we each have 2 copies of all of our genes. We get one of those copies of the gene from our mum and the other copy of the gene from our dad. So a person who has 2 working copies of a cancer protection gene has the same risks of developing cancer as the general population. But because most of the time these cancer predisposition gene faults show what we call dominant inheritance, having one faulty copy of a cancer protection gene means that you have a higher risk of developing cancer compared to the general population. And in this particular figure, you can see that the mum has 2 working copies, and you can see that she's shown in pink, whereas the dad has 1 working copy and 1 faulty copy of the gene, and he's the one living with an increased risk of cancer in this example. When parents have children, they randomly pass on 1 copy of their gene. So mum will only be able to pass on working copies to all of her children because she's only got working copies. Whereas on average, half of the children will receive the working copy of the gene from dad, and they're the kids here shown in pink, and they also have the same cancer risks as everyone in the general population because they have 2 working copies of the gene. But on average, half of the children will inherit the faulty copy of the gene from their parent, and they're the 2 children shown in white who, as they get older, will also have that higher risk of developing cancers. It's very important that you understand that both males and females have the exact same chance of inheriting a faulty gene, but the overall cancer risks that they have later in life could differ considerably. And we know that if we use the example of BRCA1 and BRCA2 genes, we know that there is a much greater risk for females with faults in those genes because there is a very high risk of breast cancer and ovarian cancer, whereas males have a smaller risk of male breast cancer and an increased risk of prostate cancer. But both of these individuals, males and females with BRCA2 gene faults, would have a higher risk of pancreas cancer. One of the other things that a genetic counsellor will do during a genetics assessment is to really talk you through all of the potential benefits as well as the potential limitations or potential harms of genetic testing to ensure that you've understood these factors and can make a decision around whether or not genetic testing is right for you. When I've had these discussions with patients, these are some of the benefits that I've been told about. For many, simply having an explanation for their diagnosis or for their family history has helped them to understand why this has happened and how they can use this information to help care for others in their family. When a person has been newly diagnosed with a cancer, genetic testing can sometimes help their doctors plan their treatments. And the reason for this is that there's a lot of growing evidence around certain treatments being more effective when there are particular gene faults. I've listed some of these treatments here, but these discussions are best to have with a medical oncologist because they know this a lot more than I do. But things like platinum-based chemotherapies or certain inhibitors and immunotherapies, for example, PARP inhibitors work quite well with in individuals who have faults in BRCA1 and BRCA2. And immunotherapy has been shown to work quite well in individuals who have Lynch syndrome. And more we're seeing clinical trials where they are doing somatic sequencing, so that's testing of the tumour tissue itself to see if there are other treatments that can be most effective on that exact type of tumour. Moving beyond initial treatment, it can also be helpful to know and to plan for future follow-up and screening tests. So this is going to really fall into that idea of knowledge is power. If you know you have a higher risk of developing a certain health problem, you can make sure that you're having the right health checks to keep an eye on that part of your body. And that is the case for various cancer screening. If you know you have an increased risk of bowel cancer, you're going to want to have bowel screening. If you learn you have an increased risk of breast cancer, you want to make sure you're having the right breast screening. For some patients with pancreas cancer who unfortunately receive a poor prognosis, I guess future management is not the initial focus or the primary concern, but this does become really helpful for any blood relatives, because if we find the explanation for why there have been cancers in the family, other members of the family who are well can choose whether or not they'd like to have their own genetic test to learn if they have or have not inherited the same genetic fault. If a person learns that they don't have the faulty gene, this can be really reassuring for them, because they'll know that their risks of cancer is the same as the general population. Whereas if we can identify those members of the family who have also inherited the faulty gene, then we can tell them and help guide them to know exactly what screening they might benefit from over time. But on the flip side, as I said, all genetic counsellors also talk around the possible limitations or the possible harms of genetic testing. And we recognise that some people simply do not wish to know if they have an increased risk, and a genetic counsellor will always respect that choice. We know that learning that you do have a higher risk of certain health problems like cancers might cause worry or fear around your future health risks. We also know that our understanding of cancer genetics is far from complete, and there are many families where we don't yet find an explanation, or perhaps sometimes when we find a result that we don't fully understand. We can find changes within genes that where it's not clear to us if that change is causing the gene to be faulty or not. And sometimes living with these uncertain results can be also quite challenging for families. And then finally, there are also some important considerations for things like insurance products. And here I'm referring to things like life or income protection insurance. Now, I don't have a lot of time to go into this in detail, but I have included a link to a fact sheet on this particular topic if this is of interest for people. But generally speaking, insurance companies are legally able to ask you if you have had a genetic test, and you do have an obligation to tell them if you have had a test and what that result was. There are some, restrictions on the use of this information in place until June 2024, but there are limits to, to the amount of that premium, the amount of cover that you will receive. And if you go above that amount, there is still this need to disclose genetic information. So 2 resources that I think might be helpful in this scenario is the Centre for Genetics Education website, which not only has a list of all of the cancer genetic services across the country, but it does have a number of other fact sheets available on their website, including the insurance fact sheet that I just mentioned. And you can see in the top right-hand corner of their webpage, there's a link to a whole bunch of helpful documents around cancer genetics and genetics in general. And the other resource that I think is quite helpful is EviQ. EviQ is our national cancer guidelines. There is a whole section on cancer genetics as well as other fields of cancer treatments. And there are some really important risk management guidelines as well as consumer fact sheets for families where there have been certain gene faults identified. So moving on from that process of genetics assessment to what we do with the information that you learn from a genetics assessment. So if this assessment does indicate that you have an increased risk of pancreas cancer, what can you do about it? The number one thing that we always come back to is it's really important to control your environmental or modifiable risk factors. So things like avoiding smoking, limiting alcohol, maintaining a healthy body weight through diet and exercise, these are all things that we all should be doing to minimise our cancer risks. But I'm the first to admit that there's several things on that list that I still struggle with. But it really does become even more important if you're living with an inherited risk that you do try to control these modifiable risk factors. The other thing, of course, that you can do is have regular checks of your pancreas to hopefully detect any early signs that a cancer could be developing. The idea around pancreatic cancer screening first came about when the Cancer of the Pancreas Screening Consortium, or the CAPS Consortium, formed in 2010. This consortium is a group of over 35 different research programs all around the world who are trying to coordinate a global approach to pancreatic cancer screening. We're still researching the optimal protocols for how to perform these checks of the pancreas. And because of that, it is very much still strictly a research process. It is not a clinically available test at the current time, and it is still only recommended for individuals who are considered to have the highest risk of pancreas cancer, which are those who are assessed as having a greater than 5% lifetime risk. So why are we running this as a screening trial, and why isn't this something that we're offering to everyone? I wanted to show our current Australian data around pancreatic cancer, and these two graphs essentially sum up why this is something that is still being investigated in a research setting. Pancreatic cancer is not common. It was estimated that there were around 4,200 new cases diagnosed last year in Australia. And whilst these numbers are unfortunately increasing, you can see it is still far fewer cases than the more common cancers like breast cancer or prostate cancer or bowel cancer. But unfortunately, unlike those more common cancers where generally survival is quite good, unfortunately, most of the individuals diagnosed with pancreas cancer will pass away from their disease. And when we look at the graph here on the right, over the last 30 years, you can see that the overall 5-year survival rates have remained very low. Whilst over the last 10 years or so, we have started to see this small increase in survival, and I'm now happy to say that that is increased to 12%. It is still far too few individuals surviving their disease. Because it's so rare, population screening is just not feasible. But to improve these survival rates, we need to be able to find who are the individuals with the highest risk of pancreas cancer. And if by inviting them to participate in screening programs, we can develop an understanding of how best to do this, then it does become a much more, appropriate strategy for us to try and make these improvements in survival. So I just want to talk you through our current understanding of how pancreatic cancer develops. And you can see in this figure, as we move from the left-hand side of the screen to the right, the cells of the pancreas can undergo a series of changes where they develop from a normal cell of the pancreas to a low-grade abnormality through to a higher-grade abnormality called the PanIn3 lesion. And these PanIn3 lesions can then unfortunately develop further into an invasive cancer. And then that invasive cancer can spread through the bloodstream and can unfortunately metastasize to other parts of the body. Unfortunately, it is often only after the pancreas cancer has spread to other parts of the body that that patient becomes symptomatic and is diagnosed with their cancer. The goal of screening is to try and detect these PanIn3 lesions, these high-grade abnormalities before they've become a cancer, and to intervene with treatment or surgery at that point to prevent the cells or that lesion developing into an invasive cancer or to spread outside the pancreas. So whilst we have a clearer goal of what we're trying to do or achieve through screening, The difficulty is we still have no current clinical proof that screening will be helpful. But we do have some preliminary evidence which is certainly encouraging. And I point here to two different studies. There was a study a few years ago now by Liu et al. Who reviewed 16 different screening programs. And their study found that if a patient's pancreas cancer was detected through screening, more of them could have surgery that was intended to cure them of their disease and that they survived longer. More recently, Canto et al. Published the first long-term study. And over a period of 16 years in their study, they again found that the vast majority of pancreas cancers that were detected by screening could were operable, and that if a person's tumour was operable, then they had a greater chance of being alive 3 years after their diagnosis to compare to a smaller number of people who were unable to have surgery. The really challenging thing for us is that even with all of these studies running all around the world, the overall number of individuals being diagnosed with pancreas cancer in these studies is still very small. Now that is actually really reassuring, because even amongst the people who have the highest risk of developing pancreas cancer, majority never go on to develop a pancreas cancer. But it does make our job as researchers really tricky, because it's taking us a very, very, very long time to determine if there is a clinical benefit by doing this screening. And what we're doing now is combining all of the information about all of our patients here in Australia. We're sharing those with the other researchers in the CAPS consortium to generate one big group of patients to try and see if we can accumulate this evidence faster. So who do we recruit into the Australian Pancreatic Cancer Screening Program, and what's involved? So we recruit people who are aged between 50 and 80 years of age if their family history meets familial pancreatic cancer criteria. And by that, I mean if they have 3 or more relatives with pancreas cancer, with at least one being a first-degree relative. Or if there are only 2 pancreas cancers in the family, then both must be a first-degree relative of the person being screened. We recruit people with a clinical or a genetic diagnosis of Peutz-Jeghers syndrome and hereditary pancreatitis from the age of 40, so a little bit younger. We recruit BRCA2 gene fault carriers from the age of 50 if they have at least one first or one second-degree relative with pancreas cancer. And then we recruit the other gene fault carriers. So these are people with a faulty PALB2, CDK, N2A, ATM, or a Lynch syndrome gene from the age of 50 if they have at least one first-degree relative with pancreas cancer. We do not currently recruit BRCA1 carriers because the current evidence suggests that this is a moderately increased risk gene, not a high risk gene. And we also don't recruit gene fault carriers who do not have a family history of pancreas cancer. There are some other health conditions that do make screening unsafe. So at the time of enrolment, the clinical research coordinator or the study gastroenterologist will ask around past medical history, and there are a few things that we do exclude from the study, but this is something that was always assessed on an individual basis. The technique that we use most of the time in our screening program is called an endoscopic ultrasound. Now, some of you may be familiar with an endoscope, and that is a long flexible tube with a camera on the end of it, which is inserted into your mouth while you are under sedation. And it's very similar to this, except that this particular endoscope also has an ultrasound probe on the end of it. So as I mentioned, you are sedated, and this tube is put into your mouth and directed down into your stomach, where it can take an internal ultrasound of the pancreas. and it looks a little bit like this. Sometimes the study gastroenterologists can see a lesion growing in the pancreas, and if they see something that is suspicious, there is also a small needle that can take a biopsy at the same time. But this is only done if there is a suspicious lesion seen. It's important for me to stress that the endoscopic ultrasound is an established technique in gastroenterology. It is currently used in the diagnosis of pancreas cancer, and it's only its use as a screening tool for a person who has no symptoms of pancreas cancer that is under investigation, so not the technique itself. When a person joins our screening program, we ask them to complete a consent form, as well as an initial personal and family health history questionnaire. There is a formal genetic counselling appointment, which may or may not involve genetic testing. They are then undergo an endoscopic ultrasound and a blood test. When we do the blood test, we do look for some basic clinical markers, but we're also taking a research sample to try and see if we can develop a new biomarker to detect pancreas cancer early. If the endoscopic ultrasound results are normal, we continue every year for 5 years. But if those results are abnormal, the gastroenterologist might recommend checking in at an earlier time point, say after 3 months or 6 months, or they might recommend an intervention such as a surgery. The process here is for us to help understand how lesions of the pancreas can progress, when is the best time to intervene with a surgery, and of course to determine if there is a clinical benefit of detecting lesions early. After the first endoscopic ultrasound, there's a brief follow-up call with the research coordinator to check in around how you found the procedure and to see if you've had any questions. And we ask you to complete brief follow-up questionnaires 1 month, 1 year and 5 years after joining the study. And this can allow us to get a sense of your overall experience of being involved in the screening program. So our screening trial began back in 2011 at St Vincent's Hospital in Sydney, and I've been the coordinator there since 2017. We expanded to Austin Health in Melbourne in 2015, and since that time we've recently expanded further to Royal Brisbane and Women's Hospital, to 2 additional sites in Melbourne, the Royal Melbourne Hospital and Epworth Healthcare in Richmond, and also Sir Charles Gardner and Hollywood Private Hospitals in Perth. So we are now becoming a truly national program. I know that there are still some additional states where unfortunately we don't yet have screening available. It is possible for individuals living in other states to travel to their closest or to their preferred site. And obviously we know that some people that is feasible, but for others that is not feasible. So one of the questions that I always get asked is, well, what if I don't meet the criteria for the screening program, or if I can't travel to one of those screening sites, but I still want to know what I can do to help keep myself well? I always recommend having a conversation with your GP. Your GP is your primary healthcare provider, and they are going to be able to try and provide some initial options in terms of any tests that they could perform on a regular basis, or can put you in touch with certain specialists through a formal referral. The 2 specialists that I would suggest is, of course, to come and see a cancer genetics service. Having a formal, personal and family history risk assessment can help you to understand what your chances are of having an increased risk of cancer, whether or not any genetic testing is recommended, and certainly to have some advice regarding your cancer risks and recommended screening tests. And to potentially also see a local gastroenterologist. There are more and more gastroenterologists offering privately funded screening tests for pancreas cancer. Now, some of them may be familiar with the endoscopic ultrasound technique, or some of them may use some alternate tests such as an MRI or a CT scan. So just super quickly going through some of these other tests. MRIs are something that we do also use in our screening program. And the benefits of this particular test is that it does show quite a lot of detail within the pancreas, and it actually uses radio waves and a magnet rather than radiation to get that image of the pancreas. As a disadvantage though, it does take quite a long time to get this scan done. It is a loud and an enclosed machine, which is really difficult for some people to tolerate, and it is an expensive test. And as I mentioned, at the moment, this is not a test that is clinically available or that is paid for by Medicare. So it is an out-of-pocket cost for people to have MRIs. The other test, a CT scan, is certainly a shorter scan and it is a less expensive scan, but it does use radiation. And whilst having a CT scan once or twice in your lifetime is not really going to cause any problems, if you're having a CT scan as a screening test every year for 30 or 40 years, the cumulative amount of that radiation might start to become a problem. There is also some data that suggests that endoscopic ultrasound and MRI is a better test to have than a CT scan. And this data goes back to 2012 when Canto and colleagues looked at their screening participants, and they found that of 216 participants, 42% of them had one or more abnormality on their pancreas. Now that does seem very high, but it is very important to note that none of these individuals had a pancreatic cancer. There were 84 cysts, 3 solid lesions, and 5 patients with a dilated or an enlarged pancreatic duct. None of these tests found every abnormality. The CT and EUS missed some of the cysts that were seen by MRI, and the CT and the MRI missed some of the lesions that were detected by endoscopic ultrasound. And this did include 3 neuroendocrine tumours. So whilst neuroendocrine tumours have a much better prognosis compared to pancreatic ductal adenocarcinoma, it's obviously still very important that we do detect these lesions, and EUS was the best test for those particular types of lesions. And if we look in the table here, you can see that overall MRI and EUS had pretty comparable detection capabilities, but the CT scan was had a far lower ability to detect these lesions. And it's based on this data that the screening program stopped using CT scans as the main imaging test for screening. The other question that I get asked a lot is, is there a blood test? Unfortunately, the short answer is no. We don't yet have an effective blood test to screen for pancreas cancer. There is a marker called the CA199, which is currently used in the diagnosis of pancreas cancer, but overall it is not that good. It is increased in around 2/3 of patients with pancreas cancer, but we know that some people can't make this protein, and we also know that some benign lesions can cause an increase in this marker, so it's not specific for pancreas cancer. Sometimes a simple fasting glucose level can check how well your pancreas is working, with the idea that if a person suddenly develops diabetes, that there could be a reason, including a tumour or a growth on their pancreas that's causing that. But again, that's not really specific, and we know that most people who develop diabetes have not developed diabetes because there is a lesion or a cancer on their pancreas. It's simply because diabetes is becoming more and more common. Where we do hope that we're going to be able to have a blood test in the future is this test that's under development called a liquid biopsy. This is a test that is actually looking for small fragments of DNA that have come from cancer cells that are floating around in our bloodstream. Now, this is not yet available. It's possibly something that might be available over the next 5 to 10 years, but it is most likely going to be a very expensive test, and who knows yet when and how this is something that might be actually introduced as a screening test for cancer. So, taking on board all of the different information around screening that I've had so far, what would be the potential benefits? And importantly, what would be the potential limitations or risks about having screening if this is something that you're thinking about? Obviously, the overall goal of screening is that we might find something, a problem on your pancreas that indicates that you have a precancerous or an early cancer, and we could intervene by offering medical treatment and improve your survival. We might also be able to provide reassurance by doing regular checks of your pancreas and letting you know that, yep, everything is looking okay. And importantly, from my perspective, we might learn more around how pancreatic cancer develops and how we can best detect it early by contributing to a screening program where information about your clinical outcomes is monitored, tracked, and ultimately published. But on the flip side, as I mentioned, there are known limitations and known risks. And this comes down to the fact that every medical investigation has a risk. Some of these risks might be really small, but some of these risks might be really serious. And this is why we have to consider them. I've mentioned that EUS is an invasive procedure. There are a number of possible complications. The one that I hear about the most is that participants say, look, I did have a sore or scratchy throat for a couple of days after the procedure. Majority of them don't develop anything beyond that. Some have said, oh, I felt a little bit drowsy for 24 hours after I came out of that sedation. At a more serious end, sometimes a person could develop pancreatitis, inflammation of the pancreas, though this is something that's often only an issue if a biopsy has been needed. And as I mentioned, we don't routinely go around biopsying the pancreas. And at that very extreme end, the endoscopic ultrasound might cause damage or even perforation of the esophagus. Now, thankfully, that is obviously very rare and certainly nothing that I've experienced since being involved in our screening program, but nonetheless, there is that small risk that people need to be aware of. But likewise, MRI, it does use a contrast agent, which in repeated doses can cause damage to the kidneys. And as I mentioned, being loud and enclosed, it's not a suitable test for certain people who might have claustrophobia, or if they have a metal implant or medical device, that magnet is not safe to be used for certain individuals. And of course, I've mentioned that CT exposed the patient to radiation, which should obviously be avoided in repeat doses. It's because of these risks that screening is only justified for those who are believed to have the highest risk of developing pancreas cancer, because it's only in that scenario that the benefits of screening outweigh some of these risks. Because we have limited data on the long-term outcomes from screening, we can't guarantee that we're going to make a difference at all to your health outcomes or to your survival. And because of that, we might also be providing you with false reassurance. It's possible that our screening tests might find an uncertain or an incidental finding that might mean you need to go on to have other medical tests. This could increase worry or anxiety, or we might intervene inappropriately and recommend surgery for a lesion on the pancreas that was never going to develop into a pancreas cancer. And there are also a number of logistical and financial factors. Whilst being involved in the screening program doesn't cost you anything, it does cost you your time, and it does involve travel and sometimes accommodation costs to be near a screening site if it's some distance from where you live. Because you're unable to drive yourself home after undergoing sedation, you also need a support person to take you home. So not only is it a time cost for yourself, it's potentially a time cost for a family member or a friend. Now, learning more around some of these barriers and how we might improve some of these challenges in terms of our screening participants being able to access screening is something that I'm really committed to. And we do have some planned future research where we're going to hopefully work with PanCare to overcome and improve some of these challenges. So I've certainly provided a huge amount of information today. I want to now just briefly summarise my main take-home points. I hope I have explained to you that we know certain people have an increased lifetime risk of pancreas cancer, and this is because they've been found to have a particular gene fault or because they have a strong family history of pancreas cancer. But even with all of these risks, high-risk individuals are still more likely never to develop pancreas cancer. A formal genetics assessment, which may or may not include genetic testing, may assist you to learn if you are at an increased risk of pancreas cancer and to understand your screening recommendations. Controlling modifiable risk factors is very important, particularly for those living with an inherited cancer risk. Pancreatic cancer screening is available through a research study, and whilst we don't yet have proven clinical benefit of this investigation, we certainly have some preliminary data that is encouraging, but all of the potential benefits and the potential limitations or risks should be weighed up in relation to your specific circumstances before being involved in our screening trial. So with that, I would thank you for your attention and happily take any questions. And I'm just going to forward through to the next slide as well, where you can see the contact details for all of the local site coordinators, so you can reach out if this is something that you'd like to discuss in more detail.
Thank you so much, Tanya, for your presentation today. A few more